one of the things that you offer ketamine, right?
Hmm.
For not exactly pain management, right? But for treatment of depression, because we all know depression affects millions of Americans. People are lost their interest in life, anhedonia, we call it. And
Hmm.
these people are depressed and they don't respond. It's like 50 or 60% of people don't respond to the first line therapies, the SSRI, things like that. And so there's been a lot of research into ketamine. And I know that you offer it to your patients. Tell me about ketamine. Tell me about the receptors involved. Tell me how you use it in depression.
So ketamine's been around since the 50s, came up as an anesthetic, commonly used in veterinary medicine because you can give an intramuscular injection and doesn't cause respiratory depression. Right. Other anesthetics, inhalation anesthetics, propofol, opioids, they can all decrease respiratory drive. So it's common in veterinary, but we've used it in anesthesia since day one. So it's a good adjunct medicine, especially someone who's older and frail and you're concerned about their pulmonary status. You may use more ketamine than you would otherwise in someone to minimize the deleterious effects of other general anesthetics. That being said, about 15, 20 years ago, they noticed that number one, high doses of ketamine from pain patients was helpful. Low doses in depressed people were very useful. And long circuit's a story about both of those, but needless to say, ketamine is a central acting medication. Essentially works on glutamate at guess what receptor?
An NDA receptor.
That sucker. He's always coming back into the picture.
Yeah.
So what happens typically is when you administer ketamine, first thing happens, all the glutamate's emptied out. And what we see in depression, also in pain, but in depression particularly, you have these heart tracts that are wired with depression. And what the ketamine does is frees up these bonds between this cortex to limbic. And the limbic is the first original part of our brain.
Emotional.
Yes, it's where our emotions are stepped. It's how we express, it's how we deal with pain or depression and or other difficult, stressful situations in our life. So we know that these limbic attachments are very strong in depression. The ketamine, via the essentially inhibition of glutamate, will allow some of these hard tracks to start not being so hard tracked. So when we look at most of the evidence with ketamine and depression, comes out of Yale. They have been the pioneers in this. And their standard is 6 sessions, 2 a week or 3 weeks. And that tends to give it more longevity. When people come in and they say, well, I'm not sure, but I want to try it, we mandate 2 sessions because one is usually not enough. And they almost always respond. I would say 80% of the people respond in a very, very positive way. But the durability is not there. So we encourage them to do more. Typically what occurs is they'll meet with our psychologist just to explain what's going on and how you'll feel and all this. And she's undergone ketamine for depression herself numerous times. So she gets it. She understands. So she's not going to take you away from your own therapist. She's going to be a coach essentially for this treatment. They'll come in, they'll meet with her. Then we set up a couple sessions where we have a care nurse monitoring the patient, infuse ketamine for about an hour, usually at a milligram per kilogram basis, which was a little higher than the Yale stuff. But when you dissect the subparts of Yale studies or any studies in ketamine, more is better. Mm-hmm. So it's still reasonable. You're there for an hour, you're kind of goofed up for the rest of the day because ketamine is a dissociative anesthetic. It kind of takes you out of your body. You may hallucinate, you may not. So, but those are good things. We want that to occur. We avoid any of the benzodiazepines because that's inhibit exactly what we're trying to do. So if someone's getting a little stressed, we may turn down the volume of the ketamine at the time it's being administered. We really want to avoid any benzodiazepines. Benzos, Valium, Xanax, Klonopin, Ativan, all these are long-term extremely negative for your brain.
Yeah.
Not only for depression, but for Alzheimer's and other forms. So we don't want that to occur, not in the short term, not in the long term.
Yeah.
If I travel, I might take some Xanax with me so I can sleep and when I'm somewhere else, but periodic use of that's not a problem, but the chronic use is definitely fraught with a lot of problems.
Yeah. So, the way I imagine ketamine working because I always like to come up with analogies
Hmm.
to help my
You're good at that.
patients, right? And one of the things I was thinking of is I was like, if you think about the nervous system and you think about pathways that have been created, just like in chronic pain, where you get this pathway and your brain knows that there's going to be pain and hardens that pathway. Same thing can happen with depression. So you have these pathways in your brain that are created, right? And you've got the depression pathway and the nerves are firing and
Hmm.
going, whatever.
Hmm.
I think of ketamine as if you have a paved road that's leading to a cliff and the car is driving and you can go off the cliff. That doesn't sound very fun. But just imagine when you get ketamine, now you've got construction coming in. They've broken up that road and they're trying to take you somewhere else.
That's
Maybe they're
exactly
taking you
right.
towards the beach
That's
instead
right.
of towards the cliff, right?
Uh-huh.
And so you're able to almost, redesign how those pathways are hardening.
You're breaking down the Autobahn into side streets.
Yeah. And
Hmm.
and you're allowing yourself to go to a happier place, which I think, sometimes it can be an issue in depression. And I've seen, depending on what study you're reading, some of these rates of efficacy are like 80%, 75%, like, which is really high in terms of these patients being, not having depression any longer. Yes, we're going to need repeat
You,
therapy.
you might, yeah, it's not unusual, but my take is we all get depressed. Okay. Something bad happens. Oh, we lost some money. A kid got sick, whatever it is. We all get depressed. But those are usually situational, time based things that resolve. Okay. Death of a spouse, whatever. Those are normal things. But if someone is suffering and they get to the point where this is now chronic, truly, I would advocate just doing the ketamine before you get on an SSRI or a SNRI. Why not? Because why go through all this and be subjected to this lifelong commitment to the pharmaceutical company where you can cut it in the bud. So even though the indication is for medication refractory depression, I've seen it when we've done it with people who have relatively new onset.
Yeah.
We get a referral from a psychologist who's like, this person, doesn't want to take the antidepressant medication. Would you consider? I'm like, absolutely. And to be honest, those people are done better than anyone because you get it early and they're not subjected to months or years of, but not to say that, antidepressants are bad because they really help a lot of people. So I don't want to just minimize that and say they're not good. But if it was my family and there was looked like it was real depression that was kicking in, it was going to be a chronic thing. I would administer ketamine first.